Gleich. Okay, I think we should start now. It's shortly after 5. I welcome all who are joining us to the third webinar of the vascular section of the EANS. Again, I'm quite happy that we found a well-known speaker for giving the talk. Today, Professor Gruber from Linz, Austria, will give a talk on the multimodality management of cerebral aneurysms. I truly believe that's a very interesting topic. He will give the talk for 45 minutes, and after the talk, we will have, let's say, 15-20 minutes for discussion. I would appreciate if you could put your question into the F&A section, and then I can read them and not using the chat for answer for the questions. It makes it a bit more easier for me. So, Andreas, I'm happy that you're here, and we are appreciating to hear your talk. Please.
Thank you very much. As you hear from my voice, I'm a little bit my nose is closed, so I will probably interrupt a couple of times to clean it. I hope you apologize. I'm far away from you, so there is no way of contracting anything. Okay.
Okay, great.
So let's share my screen, and I give you this presentation. Well, the bottom line. Yeah. So I always start the presentations with this slide. This is boring because you all know it, yeah. But I think there's a lot of information on this slide. On the left-hand side, you see that aneurysm treatment that there are many ways to do, and this clip versus coil debate is more or less insufficient because there are so many more possibilities. The bottom line is that there are reconstructive and deconstructive procedures. And you see, reconstructive means that you occlude the aneurysm, but the parent artery stays open. This is clipping, this is coiling, this is anything like stenting. And you see that clipping, coiling, stenting are, physiologically speaking, in the same category. This is reconstructive. And then you have the deconstructive procedures. They are, of course, the minority, like parent artery occlusion, with a bypass, and so forth. So you occlude the aneurysm together with a parent artery. So this is a strategy that you usually cannot get along with in the brain, so only under certain circumstances. On the right side, you see that when you apply those 6 procedures, so clipping, coiling, stenting, and deconstructive procedures, you have a whole lot of clinical and anatomical scenarios that more or less determine which procedure is feasible and which is contraindicated. It means you have small-based, broad-based aneurysms, patients with and without subarachnoid hemorrhage, those with intracranial, intracerebral hemorrhages. You have patients with difficult angiomorphology, like old people with hostile or aortic arches. You have patients with comorbidities. You have poor grade or good grade patients. You have aneurysms in the anterior and posterior circulation. You have vasospasm or not. And this dictates, of course, which treatment technique makes sense and which does not make sense. So you will not coil an aneurysm only because it's small based when you have an intracranial hemorrhage. You will not do extensive surgery in an old patient with comorbidity or in a patient with vasospasm. You will not stent the patient after subarachnoid hemorrhage because you might need external ventricular drainages or pressure probes, and then the patient is under double antiplatelet medication. You will not occlude an artery, parent artery occlusion, in a patient with subarachnoid hemorrhage, because later when the vasospasm takes over, all the collaterals that might have functioned on day 1, they will no longer function on day 10. So there are many things to be considered. When we start now, the underlying idea is the following. Surgery is trauma, and this is what the endovascular people argue when they say you should embolize aneurysms. Of course, some endovascular complications are at least as traumatic because you have no way to properly handle them. Hemorrhage is hemorrhage. And of course, some retreatment, repeated retreatment, if the first treatment is inappropriate, is also trauma and also carries a certain morbidity. So in my understanding, there is no such correlation like minimal invasiveness justifies minimal effectiveness. Yeah? And it also does not say that maximal invasiveness, like surgery, guarantees maximal effectiveness. But of course, it does not mean that minimal invasive coiling justifies minimal effective results. Of course not. Yeah? That means when we talk about clipping, I just show you some very, let's say, aggressive cases, or let's say cases with large aneurysms and so forth. Because the common saying, of course, goes that everything can be coiled, everything can be embolized. Well, it's true, but the question is, what is embolization? When the person means everything can be embolized, and he means you can put something into the aneurysm in every patient without hurting him, that's correct. Yeah? But when we talk about treatment, we talk about permanent, total angiographic obliteration of the aneurysm. Yeah? This is not stuffing something inside and running away. Okay, of course. So when you look at the challenging lesions, they are more or less the justification for surgery. And then, of course, you can come down to the smaller ones, and then you can say, you can clip them, you can coil them, whatever. But there are lesions where you don't have so many options. You can Y-stent this patient, that's possible. You can bypass it, of course. You cannot coil it because the coils will more or less sink into the thrombus and it will recur forever. So it means you have a large aneurysm, you open it, you do thrombectomy, you clip it, and so forth. So this is the justification for the technique. And when you have smaller aneurysms, the same principles apply. Mechanical aneurysm obliteration. To make it even worse, this does not only function in the elective cases, this also functions in the acute phases. And there is no way of stenting or web implantation, whatever. You need to operate the patient. Yeah? That means the justification for the microsurgical procedure is always there. The question is whether or not to clip or surgically treat every aneurysm. This is a matter of debate. But again, only because you have a hammer, not everything is a nail. That means I like this case report, or probably I dislike it. It's from Pittsburgh, and it shows transsphenoidal clipping of a small, broad, narrow-necked SCA aneurysm. Yeah? So again, yeah, there is no correlation. Maximal invasiveness does not guarantee maximum effectiveness. So you can easily stent it, flow divert it, whatever. Yeah? There is no need to clip this through the nose. So more or less some rational decision making, like every one of us would do. On the other side, we know the initial endovascular treatment form, this was coiling. You know those pictures, and you know the game-changing thing with coiling was that you could detach the coil. In the early 1990s, when you were placing coils and the coil didn't fit, you were an unlucky guy because the coil was out and then you had a stroke. The point is that when you have a coil that is melted to a guide wire, once the coil is inside the aneurysm, the coil fits, then you can, by electrolysis or by whatever, can detach the coil, controlled detachment. That means that only when the coil fits, you can detach it. This was, of course, now the revolution that made possible coiling of aneurysms. Now, I usually show this the next slide just to more or less to illustrate the difference between coiling and clipping from a mechanical standpoint. That means clipping does. Sorry, I have to change this because for one reason or another the video doesn't start. But this is not shocking us. So I show this video more or less to get a laugh. Yeah? but it demonstrates the difference. On the upper left, you see a clipped aneurysm. So the aneurysm blades reapproximate the artery wall, and by doing so, they occlude the aneurysm using a defined mechanical force. Here you see a coiled aneurysm, and you see that the coils induce thrombosis and endothelialization. And regardless how much you press the coils inside, regardless how much you press the coils inside, as you can see on the lower left now, you will only end up with roughly 20%, 30% of coils inside the aneurysm, and the rest is thrombus. As you can see also on those surgical pictures, where there is a lot of thrombus and not so many coils. That means, of course, this kind of occlusion is prone to recanalization if thrombosis doesn't work, or if there's a water hammer, something. That means 5 to 10% of coiled aneurysms may undergo recanalization. What is the major drawback, of course, of this technique? Whereas the minimal invasiveness, of course, is brilliant. You see here a broad-based ACOM aneurysm, and you see at first sight that this is not treatable using bare platinum coils, because coils lack what surgery has, and this is the so-called reconstructive capacity. That means when you have a clip, you can model or tailor any kind of shape at the neck. Whereas when you place coils, they only make a sphere, and they occlude everything that is incorporated into the aneurysm. In this case, you see the pericallosal artery taking off the aneurysm wall, and of course you would occlude it. To circumvent this complication means that you need Y stenting or X stenting or something, so more invasive procedures. And this now is the crucial question. Aneurysm surgery has defined risks and morbidities depending on aneurysm size, location, and so forth. But depending on your experience, those risks are usually calculated. That means you know what you can do, and usually you will perform the way you perform. Placing 2 stents into the ACOM, for example, renders the patient to unpredictable risks, of course, because you don't know how thrombosis will work. So placing flow diverters or stents has a still not sufficiently manageable risk of ischemic complications from thrombosis and from thromboemboli. And this, of course, is not there with clipping. It means the trade-off usually is not what is the more invasive procedure, but what is your morbidity and then what is your effectiveness. We often hear that aneurysms recur at the neck, but they rupture at the dome. So they say that neck remnants are benign lesions. As you can see here, this is again an ACOM aneurysm, and of course the neck remnant or the neck remnant that you saw here was thin-walled. It was red. It was rupture-prone. So in the vast majority, a neck remnant is a benign entity, but you can never foresee. When we talk about aneurysm coiling, this is again an older paper of mine from Vienna. We looked at many aneurysms, and we looked at how they used to recur. There are 2 ways, and they make a significant difference. Way 1, the aneurysm stays morphologically speaking the same, but the coils recompact. And that means the aneurysm is stable, and when the coils recompact, you can recoil them. On the other hand, when the aneurysm grows, but the coil stays the same, that means that the aneurysm per se is an unstable lesion, so you should get rid of it by other means like stenting, flow diversion, or clipping. That's a major difference in the management algorithm. But I'm not criticizing endovascular treatment at all. Yeah? There are many lesions where you're very happy that this procedure is around, and then you would not like to clip basilar trunk fenestrations anyway. So there are good reasons why this has been invented. Talking about ruptured aneurysms, you know the ISO trial, and to the ISO trial there are 3 very important, let's say, remarks. First, the ISO trial says that in the acute phase, embolized ruptured aneurysms fare better than clipped ones. Well, first, This conclusion must not be extrapolated to unruptured lesions. It only holds true for ruptured lesions. There is no trial saying that you should embolize unruptured lesions. Second thing, we were talking about the efficacy. Here you see that you can embolize everything, of course, yeah, but the question is, will it be stable or not? Third thing, and this is the most important thing, the message of ISAT is not coil the ruptured aneurysms, but it says, when an aneurysm looks embolizable and it has ruptured, it should be embolized. When an aneurysm looks clippable and it is difficult to embolize just by coils, you should clip it. And when the surgeon and the radiologist meet and they look at the case and both say what to do, no idea, this is called clinical equipoise. And in the ISAT trial, only 20% of the patients had clinical equipoise. And in those patients, you should embolize them. That's the message. So embolize the embolizables, embolize those with clinical equipoise, and then those that are easily clippable should be clipped. So there is no argument for stenting or for whatever procedures in ruptured aneurysms. The last thing, and this is even more important, is this study here. And the ISAT trial was an intent to treat statistic. That means you were randomized for surgery or for embolization, and you remained in this group forever. In the ISAT trial, as you can see, a significant portion of aneurysms rebled prior to surgery. Some of them died, but they were counted as surgical mortality. They never saw the surgeon. They died in the hospital before the surgeon came. But the ISAT trial calculated them as surgical mortality. When you eliminate those patients, the whole ISAT trial becomes insignificant. That's of major importance. That means there is no trial indicating that surgery is better for ruptured aneurysms. But of course, if you do those modifications, if you use an post hoc as treated algorithm for statistics, it loses significance. Again, there are many advantages. Look at endovascular treatment. You are completely independent of vasospasm, so you can dilate your way to the aneurysm. Once you have established your way, you can embolize it on day 5, on day 7. You don't have to care. There are new devices, and when we usually see those devices, we get sometimes some allergic reactions. Yeah, but of course, imagine you have a broad-based, ruptured, large, posteriorly pointing basilar apex aneurysm. How to treat? Stent and coil, flow divert. Yeah? You always have intraluminal devices, and they need double antiplatelet medication. Would be fantastic to have something like a device that can bridge broad necks, but be in the aneurysm and not inside the artery, an intra-aneurysmal flow diverter. So this is the web device. And of course, you don't need this aggressive double antiplatelet medication. So this is the ideal treatment, of course. Of course, web devices have in my understanding, no place in MCA aneurysms, in ACOM aneurysms, and so forth. They are implants that lend themselves for the treatment of difficult, otherwise not manageable aneurysms. Coiling and the giant aneurysms, as you know, there's a very old paper, 20 years old, but it still is true. When you have partially thrombosed large and giant aneurysms and you coil them, you can carry on coiling them forever and forever because they will recur forever and forever. That means endovascular coiling is no treatment for giant aneurysms. Final remark to the coiling: when your treatment algorithm includes coil removal for clipping, you should know when the coiling was done. When you have an acute complication like here, when you occlude the pericallosal because your coils were placed in the wrong place, you can rush to the OR and take out the coils. And I show this case only to show you how easily you can get out the coils, because it's just 1.5 hours before. A complete different story when the coils have been implanted the months before, and your clipping strategy relies on coil removal, because those coils are scarred into the aneurysm and you will never get them out like this. These are very traumatic procedures, and then probably, if you have a good chance, probably stent them or do whatever, but don't try to remove the coils. Coming to stenting. Stenting is more or less something like using a neck bridging device. The common stent is a non-occlusive device. That means placing a stent does not occlude the aneurysm because we don't use covered stents. But the stent can serve as an interface that allows coiling of broad-based aneurysms. So stenting and coiling has a reconstructive capacity similar to aneurysm clipping, as you can see here. The stent is incorporated into the artery wall, and by doing so, you can taper the antiplatelet medication after some months. And of course, there are many cases where you're very happy that this technique is around and you would not like to clip this aneurysm, but you're very happy that you can stent and coil it. And then suddenly everything is easy. Again, coiling posterior circulation aneurysms with stent support is reasonable. On the right-hand side, you see an MCA aneurysm that has a Y stenting, and then you place the coils inside, and then you don't need surgery. Yeah? Again, in my understanding, straightforward MCA aneurysm surgery in expert hands has a morbidity way lower than the morbidity of stent-assisted coiling, as you can see here. So morbidity and mortality of stenting and of stent assist is not zero. And the first number, the 7.4%, is a very old number, so probably we should no longer argue with this. But there is still a significant morbidity and mortality, way higher than coiling. That means the ISA trial results, well, nowadays we stent and coil the ruptured aneurysms, well, of course, but you add significant additional procedural morbidity and mortality. When you compare the ordinary stent with the flow diverter that you see below, you see that the pore size is, of course, larger with the ordinary stent, but the amount of metal that you use is the same, but the pore size differs. And how does a flow diverter work? Well, imagine an ordinary stent, the occlusion rate is 0. Imagine a covered stent, well, the occlusion rate is 100% at the cost of the perforators. When you have something in between, like a flow diverter, it means you have a pore size that is so small that a blind sac behind the aneurysm, behind the flow diverter, will thrombose like an aneurysm. On the other hand, something like an artery with its sump effect will render this flow diverting device open. And this is the critical point. A flow diverter occludes the aneurysm, so the blind sac, but the flow diverter does not occlude the branches, so it does not occlude the perforators. And by doing so, it becomes almost easy to manage the most complicated aneurysms just by placing a stent. And there is a downside. The downside is that when you place a flow diverter alone, you have the following cascade of events. First, there is no more contrast influx into the aneurysm. Okay. But the pressure in the aneurysm remains the same. That means the flow diverter is not a pressure diverter. You have the patient under double antiplatelet medication, and you have a flow diverter, but the pressure inside the aneurysm is still the same. So it's not the treatment for ruptured aneurysms, and it's not the treatment for blister aneurysms. When you don't place coils into the aneurysm beforehand, what happens is that slowly thrombus occurs. But this thrombus is not a static, benign structure, but it is enzymatically active, and it can digest itself through the aneurysm wall, because the aneurysm wall undergoes atrophy as soon as there is an occlusion, like coiling or stenting. Now, what happened in the first cases was you used the flow diverter, but no coils inside. The pressure was the same. The patient was under double antiplatelet medication. The thrombus got active. The wall underwent atrophy, and the aneurysm ruptured. What you do nowadays, of course, is that you coil the aneurysm beforehand, and then you place the flow diverter. So you had catastrophic hemorrhages in patients under double antiplatelet medication that were usually fatal. Flow diverters, of course, are fantastic tools when you have the proper patients. As you can see here, there's only one vertebral artery, there's a dissection, a severe stenosis. You just flow divert the patient, and like voodoo, so to say, with the intrinsic radial force of the flow diverter, after 3 months, dissection is covered. It has remodeled, and then the stenosis also has been treated. So flow diversion makes perfect sense. But again, the morbidity is even higher than with conventional stents. So the fantasy of the industry that almost every aneurysm in the future should be flow diverted, of course, Well, there is a significant mortality rate. I don't see the point to flow divert 5 millimeter ophthalmic artery aneurysms with a mortality rate of 2%. No way. That means flow diversion has its role, but it is not the future. A 10,000 euro device with a 2% mortality is not the future. Sorry. Yeah? And of course, a flow diverter is not a pressure diverter, as I indicated before. Final remark to the stenting is the following. When you implant the stent, you change the wall properties. That means when you, for example, stent and coil an ophthalmic artery aneurysm, and then you want to go and clip an MCA aneurysm, and you need proximal control, it is questionable whether or not you can get proximal control in a previously stented artery. Look at this. You can use different temporary clips, as you can see here, and we built a machine like this one that can build up tremendous closing forces. And when you look at this machine and you place it in a rabbit model and you implant different stents, like an enterprise stent or like a neuroform stent, you see that the initial closing force was this. When you have an enterprise stent in place, the closing force doubles, and with a neuroform stent, it is almost 10 times closing force. That means when you use conventional temporary clips, like in this case, when you use the enterprise stent, you can occlude the artery. But when you use a neuroform stent and you use conventional temporary clips, you have a good chance that you cannot get proximal control in this stented artery. So stenting aneurysms and stenting proximal arteries that are used for proximal control in aneurysm surgery can pose a significant problem, because then you do aneurysm surgery without proximal control, or you use large definitive clips to get proximal control, but then of course you will kink the stent and have a completely different problems. Final remark to neck bridging devices, and if you don't want stents and if you don't want flow diverters, in the acute phase, what you can do is balloon remodeling. Is we use a balloon, you inflate it across the aneurysm orifice, coil the aneurysm, and then deflate the balloon. And I couldn't believe it many years before, but it works. The coils don't jump out of the aneurysm because they are more or less broken and luxated into the aneurysm. And when you deflate the balloon, they stay there and they don't jump out. So this is a good alternative for broad-based aneurysms where stenting is not feasible, for example, in ruptured aneurysms. Now let's come to the so-called deconstructive procedures. Well, deconstructive procedures mean that you occlude the parent artery together with the aneurysm. Well, this is usually not a good strategy in the brain, as you know, and it only works when you have sufficient collaterals. And you can test those collaterals like using balloon test occlusion. And when you do so, of course, it has its advantages. The aneurysm can shrink significantly. You can resolve from compressive neuropathy in the cavernous sinus and so forth. Yeah? So, of course, it makes perfect sense. But in the vast majority of cases, you will not get away with it. So what you need is bypass surgery. And there are many different scenarios of bypass surgery, and I want to show you some. You can have in the anterior circulation all kinds of bypasses. Yeah? The term low flow bypass is wrong. I just put it here to be provocative, but low flow, what is that? I will try to show you. In the posterior circulation, you can do low flow bypass surgery, and there are some donor grafts you can use, and then some are easier to use than others, and I can only show you how I do it. And in the anterior circulation, of course, you can do any form of high flow conduits if there are no STAs or if you feel that you have to do it. I take my first sneezing breath, sorry. And back we go. So talking about anterior circulation, low flow bypass surgery, you always think about the STA, because this is the classic low flow donor graft. But of course, the STA, when you have an STA double pedicle construct, this is not necessarily low flow. Spretzler mentioned this 20 years ago, and then in Vienna I did a lot of cases, and they were not low flow. So as you can see, in this case, on the left-hand side, I'm a partially coiled, ruptured paracyloidal aneurysm, and you see the carotid artery filling in an autograde fashion. On the right side, you see now the carotid artery and the aneurysm coiled, and what you see is the hemisphere now hooked to two so-called low-flow bypasses. Now, of course, this is not low flow, and it can take care of the entire hemisphere. The point that I want to make it probably right now is the following. For as long as you can test to occlude the awake patient, you can use STA bypasses. That means in these cases, I used to have the following strategy: to do a double pedicle STA MCA bypass, then wait for 2 days, and then to test the patient, the awake patient. Why wait for 2 days? Well, 2 days are usually long enough that the patient recovers from surgery. 2 days are long enough that you can use full anticoagulation for test occlusion. And still, 2 days are short enough so that the bypass doesn't occlude, never occlude. And then you can test occlude the patient, the awake patient, and when he angiographically and clinically passes the test occlusion, then you can do the final occlusion using coiling, so endovascular. And so you can more or less undersize your bypass. When you are obliged to do the artery occlusion in the patient under general anesthesia in the same session like doing the bypass surgery, so when you have no endovascular strategy, then you should oversize the bypass. So then you have a large bypass, a vein or a radial artery. This is usually too much, but you never know beforehand. So better to have a bypass that is too large than to have a patient that is awaking and stroking. So whenever you can check it in the awake patient, STA double pedicle might be enough. STA might also be enough when you also want to replace a certain territory and not the entire hemisphere. If you can't do so, you need the vein. This image just shows you that when there are lesions that look like they cannot be reconstructed and you need a bypass, it's often worthwhile to explore the lesion. And often you see that this aneurysm, of course, like in this case, you see that this branch is not coming off the aneurysm fundus, but it's coming off the aneurysm base. And it was just a rendering artifact from the 3D angiography. And you don't need a bypass, and you can clip it, as you can see it here, very easily. So you don't need a bypass. You can also bring those STA double pedicles deeper into the sylvian fissure. So no one says that you have to hook the STA bypass up to the cortex, like cases like this. So you have remnants from previously treated aneurysms. You don't go to the cortex, but you open the sylvian fissure, and then you go to the M2 branches, and then you bring your 2 strong donor graft into the sylvian fissure, do the anastomosis, and then you have something that is, again, let's say, not a low flow bypass, so to speak. This case I like the most, just to make my point. This is a serpentine aneurysm, so partially thrombosed, ruptured larger aneurysm. The plan was to do a double pedicle STA MCA bypass, and then to do distal occlusion. We found no way to do proximal occlusion. We were afraid of the perforating branches, so we said, okay, Leglitsch and Sato, they always report their experience with distal occlusion. Let's try it. Interestingly, when the bypass was in place, as you can see, this double pedicle, so-called low flow bypass, was stronger than the internal carotid artery. So there was complete flow reversal. And now the aneurysm was filling from the periphery, as you can see here. That means the so-called distal occlusion became a proximal occlusion. That means a low flow bypass is probably a wrong term, but you can say it's an STA-MCA bypass. And if the indication is correct, if the donor graft has a reasonable size, and if it's technically correct, you can have a remarkable revascularization also with those small pedicles. The same holds true for the posterior circulation. I like this case because it shows the difficulties, but also the advantages. Rupture, excuse the German words here. Ruptured proximal pica dissection. What you can do is you can coil it. Yeah? To coil it means to risk a pica infarction, but not only in the hemisphere, but also a perforated infarction, because the brainstem perforators are also coming off proximal pica, as you know, as you can see also on the right-hand side. So you have the dissection, but you also have the brainstem perforators. When you look at this operation video, you see the dissection site and you see the brainstem perforators. So the strategy is to clip the pica takeoff, then to do the bypass in the ordinary fashion. So this is the pica loop, and then you bring down the occipital artery as a donor graft. You do your bypass, then you open the bypass, and then you look what happens. And now you can go ahead and trap the dissection, and here the brainstem perforators are preserved, which would not be preserved, of course, when you coil it. And now pica, proximal and distal, is hooked to your bypass. And when you open the bypass under ICG, as you can see, it fills backward. And by filling backward, it also fills the brainstem perforators. So this is of course, way more invasive than just coiling it. But the patient has no brainstem stroke and has no hemispheric stroke. That means in the end, you occlude pica, you have a bypass that is now filling pica, and then you see also in the CTA appropriate bypass function. And that means also, of course, when you don't do it like this, when you coil occlude or when you bypass is probably suboptimal. The first thing is, if you don't respect the brainstem perforators and you include it into your clipping or your coiling, you have the brainstem stroke. And if your bypass doesn't work, or when you just occlude pica like nothing, there's a good chance that you have the hemispheric infarction too. There is no guarantee that you have ICA, pica, or Vermean anastomosis. You cannot predict, and probably it's better to be on the safe side. Finally, talking about pica, of course, what you can do also in ruptured cases is to do in situ anastomosis. This is a ruptured case, so please excuse the blood in the operative field, but it makes sense. So when the two picas are more or less kissing, it's a good idea to do a side-to-side anastomosis. That means what is the advantage? Well, you don't need to suture a bypass, so you don't need to dissect the occipital artery, but it's usually a pain. What is the downside? Well, the downside is if this does not work, you lose both picas, like in every in situ bypass. To check whether or not the bypass is functioning, you can test occlude one artery, and under ICG, you see now when you take away the clip, then you see how the flow is crossing the sides, and then you know that the bypass is open. So that's an alternative. But of course, you can use the occipital artery for any location in the posterior circulation. For the PCA, instead of subtemporal bypasses, you can use the occipital artery with some precautions. The problem with the occipital artery, using it as a donor artery for the PCA on the occipital lobe, is that there is a significant caliber mismatch between the occipital artery and the distal PCA. And usually the large occipital artery torques and kinks on the PCA, and then the bypass occludes. For my personally, what I found useful is to try to suture this bypass interhemispherically. That means the patient is not in prone position, but in a lateral position. You have a lumbar drain. You use gravity retraction, and then the dependent hemisphere falls down, and you can get it interhemispherically, as you can see here. And then you look as deep as you can manage it manually. For a PCA branch that has a reasonable caliber, and then you can do an oblique to side anastomosis from the occipital artery to the PCA, and then you have a functioning bypass, as you can see here. That means you have the occipital artery as donor graft, but this donor graft is sufficient to retrogradely fill the parietal occipital artery, and then autogradely fill the occipital and the calcarein artery. And then again, you go ahead and coil the aneurysms. You don't even have to care about the aneurysm on P2, but you can just coil it once you have done your bypass. Anterior circulation, high flow. Well, you know Hagen-Poiseuille's equation, and you know that nothing beats the radius. So when you double the radius, you have 16 times the flow. So that's an argument, of course, and that makes it worthwhile to try high flow bypasses. That means you have in those surgeries, you have 4 surgical fields. You have the craniotomy site, you have the carotid proximal anastomosis site, then you have the femoral site, then you have the leg, you have the vein, you have part of the vein, such a vein that is something like 40 centimeters, but it's quite a lot. But in the end, your surgical field looks like this, and this is the result. And you can have, as you can see, bypasses of reasonable caliber, so to speak, and you can replace an entire carotid artery just by proximal artery occlusion and placing such a bypass. In the end, it looks like this. It is debatable whether or not the incision that the neck should be so large. I feel more comfortable, but of course there's ample space to improve. I know. Anyway, it does not make sense to go to M1 or even to the C1 M1, but it's way enough to go to M2 in my understanding. That means the problem with those bypasses is the following: the deeper you go, the more complicated is the surgery. The deeper you go, the larger is the incision. The larger your donor graft, the deeper you have to go because you don't want the caliber mismatch. The deeper you go when you're cross-clamping, the larger is the territory that you render ischemic during suturing. So the more complicated the procedure, the faster you have to suture, then the higher the stroke risk. Of course, even with barbiturate. That means this is a complicated procedure, and when you only have an M2 branch that you cross-clamp instead of M1, of course, it's only half the territory. So of course it's a bargain. So you have your proximal anastomosis, you have your two M2 branches, you cross-clamp, you use a corneal scalpel. This is the most accurate scalpel that you can find. You do your arteriotomy, you have again your anastomosis, and then you have established your treatment. If you don't tell, I can show you that you can do it even on the surface. I know this vein is looking ugly, but of course, on the cortex, it takes care of an entire hemisphere. Yeah? So the carotid occlusion, no crossflow, the entire hemisphere is hooked to this bypass. This has been published years ago, as you can see, very old paper. And usually you should not do it, of course, because you should not risk a caliber mismatch. But if you're left with the option to do nothing, you can even try the vein on the cortex, just to give you this impression. When you do this procedure, you can either use your saphenous vein in an end-to-side procedure on the external carotid artery at the neck, for example, at the inferior thyroid artery, or you can do it end-to-end. Then you simply cut through the external carotid artery and establish an end-to-end conduit. And once you have done so, then you have your vein here. Then you have to tunnel it behind the ear. I do it behind the ear. You can do it in front, of course, and all fancy things. I do it behind the ear. And then you come back, and then you have to do your proximal anastomosis. And again, as you can see, now this is an M1 anastomosis, just to show you for the sake of discussion. Again, you have here your vein that has already been tunneled. The vein comes deep to M1. You cross clamp, you need to include all the branches, of course. It means M1 proximal, M1 distal, and this temporal polar artery, as you can see here, and also this branch. This branch was not a perforator. And then you do your arteriotomy, and then you start your suturing. And of course, you suture the way that you feel most comfortable. Running sutures are faster. Interrupted sutures are more accurate. When you mix the two techniques, you may run into the complication that when you do one side running and one side interrupted, and then you open, then the back side that is usually running might get loose because your interrupted sutures have a different tension that you run, and then your running suture at the back. But usually under monitoring, and you all do this under monitoring, and then under barbiturates and under protection, then you get away with this in 25 to 30 minutes, and then you reopen, and then they have established your conduit, as you can see it here. And as I showed you beforehand, of course, it means proximal anastomosis, as you can see here, distal anastomosis, as you can see here, and it's filling the entire hemisphere. Of course, this is the sense of a large bypass. And probably I skip this. Talking about posterior circulation, well, there are no posterior circulation high flow bypasses. And even in expert hands, at the Mayo Clinic, this quotation, I think, is pathognomonic, so to say. Major undertaking should not be performed lightheartedly. And as you know, the results are very disappointing. And this is, of course, the moment where flow diversion or whatever technique steps in, and you should not bypass high flow bypass in the posterior circulation. Finally, so-called flow modification techniques. Well, as you can see, you can modify the flow in a way that you can reverse the flow, for example, and by doing so, you can occlude arteries without using bypasses. Large P1, P2 aneurysm, balloon test occluded, no deficit, coil embolized. And as you can see in this angiogram, this is now a carotid angiogram, and via leptomeningeal anastomosis from the cortex, the PCA is filling in a retrograde fashion without a bypass, simply because this leptomeningeal anastomosis were active. You have to test for this, and then only when you find this angiographic pattern and when the patient remains intact, you can occlude, and then you can do your flow modification. You can bring this even further. Bilateral ruptured bleeding vertebral artery dissections, what to do. When one could discuss nowadays some stenting or whatever, by then this was not available. What you can do is in the awake patient, you can test and you can occlude one vertebral artery after the other, of course, only when you test. The bottom line, I think this was called the so-called vascular vacuum theory by Murray. That means when you occlude proximal to picot in the picot territory due to its metabolic demand, creates such a sumpance, such a suction effect that you can drag blood via the PCOMs into the basilar artery, and then you can reverse the flow in the basilar trunk. Well, of course, this is a 1 in a million procedure. But of course, when you have appropriate PCOMs, then you can revert the flow. Also, the procedures described by Steinberg, by deliberate basilar artery occlusion, work like this. So when you occlude under controlled conditions and you have appropriate PCOMs and you have appropriate monitoring, you can get away with it. But of course, this is why this is very much at the end of this talk. This is, I would even call it experimental and probably not even feasible nowadays. Finally, there are procedures that are called endovascular tourniquets or endovascular throttle techniques, like the tourniquet from Drake. You can partially coil an aneurysm and heparinize the patient for 1 week. And when you have the patient heparinized for 1 week, this aneurysm will occlude very, very in a very retarded way. And during this way, or during this period of retarded occlusion, the collaterals can mature. And then at the same pace that the collaterals mature, the aneurysm will occlude, and you can occlude this without stroking the patient. So these are flow modification techniques, also, of course, some deconstructive procedures, but they should be wisely chosen because the morbidity is even high. At the very end, my last 2 slides, when we talk about multimodality, well, when you have a team of surgeons and radiologists doing it together and they are good friends, perfect. Like in Milan, for example, Surgeon Satta and Tony Boccardi, excellent. When you're a hybrid guy and you do both yourself, I think it doesn't make sense that you do easy surgery today and do easy coiling tomorrow, because that's not the point of hybrid. Hybrid has the intention to create procedures that are not possible otherwise. So you need to blend the 2 techniques to come to therapeutic strategies that one alone could never accomplish. This also is the rationale for using hybrid ORs. In this case, for example, you have this BB junction aneurysm, and there is no way of approaching the aneurysm from by an endovascular route. So what is being done is that you, in this case, use a surgical approach to the vertebral artery at C1 at the atlas. You puncture the artery, and by doing so, you bring the microcatheter into the vertebral artery. Second catheter is in the proximal vertebral artery on the other side. So in prone position, you can do diagnostic angiography from the left vertebral artery, and you can do coiling via the right vertebral artery. And once the aneurysm has been coiled, you take it out, suture the vertebral artery, and as you can see here, both verts are still patent, and the aneurysm has been occluded. Now, the video doesn't work, so I'm deeply sorry, but I think this chart shows you what I wanted to show you. Bottom line is as a surgeon alone, without endovascular expertise, you cannot do it. If you invite your radiologist who want to puncture the vertebral artery intraoperatively, for me at C1, he will ask you, well, what's up? So probably if you create the procedure, you do it on your own, you know what you want to do, you can create procedures that have a certain beauty because they're only possible because you are mastering both techniques, so to speak, the best of two worlds. So that's it from my side. This was what I could contribute to this multimodality management in the hands of a neurosurgeon. Could also be the perfect neurovascular team with surgeon and radiologist. In my case, some of the cases I showed you were by a hybrid guy. Thank you very much.
Thank you. Very nice and interesting talk on the management of aneurysms. So there are a few questions from the audience, and I hope a few other questions will come in soon. The first question is, how would you treat a seldom basilar perforator aneurysm with SAH, flow diverter, yes or no?
Yes, I would. Yes, I would. It's evident that the flow diverters have their FDA mark only for the anterior circulation and then only for the intracavernous and probably for the ophthalmics. And of course, flow diverters have the problem that this device has been marketed prematurely, and the company itself has no idea how it works. And when you ask the company people, they say, well, don't use it in the posterior circulation because there are the perforators. Yeah. So tell me, how do you call the arteries at A1 and M1? And so the idea of where to use and where not to use them does not come from experts. Yeah. But of course, flow diversion in the posterior circulation, when you have nothing else available, is a very appropriate solution. It's always a question of what is the inherent morbidity of your procedure, what is the morbidity of the natural course of the disease, and what is the morbidity of the alternative procedures. So flow diverting small ophthalmic artery aneurysms probably makes no sense. Now, flow diverting ruptured basilar trunk or apex aneurysms that don't lend themselves to clipping, coiling, whatever, makes perfect sense.
Yes, thank you. We are now confronted more and more, or at least I am, with the new wave of flow diverters, which are the mini flow diverters. Do you have any opinion about them? Are they truly different from the, let's say, normal flow diverters, or are they only another name for the same problem?
Well, they are basically the same, of course. But of course, you know, the initial or the original flow diverters were built for a certain artery caliber. This, of course, limits them to proximal aneurysms at larger arteries. And if you want to go further distally, you need those mini flow diverting devices. Because when you use the large flow diverters in small arteries, you would occlude the artery. Of course, you could use it, for example, for fusiform peripheral aneurysms, for example. No? So there are many good indications. And they're not feasible for flow diverting pica aneurysms, for example. It's complete rubbish. But of course, there will be good indications. Industry will try to aggressively market it for every aneurysm again, and we will have to look at the data, and then they will reject this offer again.
Okay, there's another question. I just read it. You mentioned that in ruptured cases, those aneurysms which are easily clippable should go for clipping rather than endovascular therapy. Which ruptured aneurysm would fall into that category, in your opinion?
Well, in the anterior circulation, that means when an aneurysm is broad-based, small MCA bifurcation aneurysm ruptured. Yeah. So this is nothing for bare platinum coil embolization. So ISAT does not say that you should at any cost try to suboptimally coil occlude this aneurysm, broad-based ruptured MCA, because it's ruptured. No, you should clip it. And ISAT, because there were no stents around, does not say that you should stent and coil a small ruptured MCA aneurysm. So whenever the surgical treatment is straightforward and the endovascular treatment is something like, let's try, I don't feel good about it, but ISAT tells me to do so, that's wrong. You know, when it's good surgery and complicated embolization, it should be clipped, of course.
Okay, it's a question from the same person. It is widely accepted now that most posterior circulation aneurysms are usually managed best with endovascular therapy. Are there any exceptions to this rule, in your opinion?
Exceptions are getting rare, yeah. But of course, if you have, for example, access problems, if you don't get your catheter up, if for one reason or another, you cannot anticoagulate the patient, blah, blah, blah. So these things. Recurrences of previously coiled aneurysms. Yeah? You know the Brad results. That means in the pica territory, when it's ruptured, it's a good choice to coil it. Basilar apex goes without saying. So in very rare cases, you can advocate it. The problem is, of course, if you say, well, in the rare case I do it, yeah, then you should know how to do it. So when you cannot embolize it, you should not try basilar artery aneurysm surgery, of course.
Well, what's your personal opinion about the VA pica aneurysms? Because I often have, no, that's not so frequent, but sometimes I have the discussion with our neuroradiologists about the patency of the pica itself, which can be hampered by the coils. And in my opinion, clipping a pica aneurysm, if it's not too big, is not so difficult. What's your opinion? What's your opinion about these special type of aneurysms?
Well, exactly, because pica usually does not take off the VA, but it takes off the aneurysm itself. So it is more or less it comes from the aneurysm neck. That means when you coil the pica aneurysm completely, then you have to occlude pica. This is why you use some fenestrated clips so often with pica aneurysm clipping. I think for surgery, when you don't come from let's say from a prone position between the lower cranial nerves, but when you come far lateral and more or less in a tangential fashion, following the VA, then you will not hurt those nerves, and you can safely clip it. I never would sacrifice pica because the existence of an anastomosis is highly unpredictable. You cannot test occlude it, you cannot balloon occlude pica and look what's going to happen. But you have to hope, and then hope is my understanding, and no valid strategy in neurosurgery.
There's another question from an Austrian neurosurgeon. Do you think there exists something like a hybrid neurosurgeon who can master both techniques on the same high level, especially with endovascular techniques and devices rapidly evolving?
And that's always the question that you have to be very honest to yourself when you answer. I personally think that the time that you devote to learn ventral dorsal stabilization or stereotactic neurosurgery or whatever, yeah, is at least as much as you need to devote to learn endovascular procedures. And then you still are treating the same disease using different devices, different tools. But your knowledge about the disease still stays the same. The point is true that the endovascular tools are rapidly evolving, and then every month there's a new something, and it becomes very difficult to keep track with all those innovations. That's perfectly true. But I simply don't agree that you can only do one on a high level.
As another question from Radik Fritsch. He is saying that it was a nice lecture, and he asked, do you really consider flow diversion unsuitable for blister aneurysms, even as a rescue solution?
Yes, this is again a good point that we can discuss longer. But of course, when you say a flow diverter is not a pressure diverter, then it should be inappropriate. I completely accept that there are now so many case series where they treat it with flow diversion and then they treat it perfectly and always wait for the ruptures, and they don't occur. So the more cases are being published and that are being presented at meetings, the large case series that are managed brilliantly, you have to ask yourself whether or not clip wrapping can compete with it. Usually not. Yeah. So I think that the strategy is in a process of being defined, and is probably now changing towards flow diversion. Yeah, that's true.
There's a question in the chat, and he asks about the percentages of procedures you're doing either endovascularly or surgically in your department last year or that year. So rough estimate.
It should be 50-50. That means you have more ruptured cases because we have a large catchment area. On the other side, we have a certain bias because we have a certain referral base that probably provide us with more complicated cases. So this more or less gives this trade-off. Yeah.
Do you think, that's a question from me, that you should look at a certain percentage for microsurgery just to stay in training if you're giving too many aneurysms to the endovascular guys, so that you're losing these aneurysms for training or for your own experience?
I think it depends on the team spirit, what to say. Yeah, usually you can make deals. Yeah, so if he wants so badly web devices for the next congress to show the pictures, and you want so badly aneurysms to teach your young residents. Yeah? So I think it's when you get along neatly, then there's always a way.
I also have a question. Have you any experience about clipping aneurysms which have been pre-treated with web devices and which has had growing remnants? So I operated now 2. Do we have any experience, or do you know how if it's easy task? For me, it seems as it's treating like a coiled aneurysm, but I would like to know if someone or you have different experiences.
I have not done, but it should be like a coiled aneurysm, probably even easier because there's not so much material inside the aneurysm.
I see another question from Daniel Walsh. The performance, which is occlusion and safety between different intrasaccular flow disruptors, seem to vary a lot between devices. Have you any insights into why this is, or advice on how they should be integrated into your practice?
Well, I know the numbers for the web device, and this is why I introduced the web device in this way, because of course the numbers are not bad, I think. Of course, there are a couple of papers describing that the morbidity of web devices in the MCA is way higher than with clipping in expert hands. I have no idea why other devices like Luna and so forth, why they don't perform this way. But I think it's, if you ask me, I'm speculating. Yeah? There are a couple of flow diverters that perform completely differently. So you had the pipeline that was perfect. Then you had the surpass device that was usually at the beginning not so easy, and then you had the others, Elvis. Yeah. So they're small differences in the construction of the device seem to make major differences in long-term stability, but also in procedural complication rates. But this is my personal opinion.
I personally fear a bit that the web devices will be used more often in the future, especially in the MCA aneurysm. You showed the example of the basilar tip aneurysm, which was treated by web device or with a web device. But if you're looking into the angioarchitecture of an MCA aneurysm and a basilar tip aneurysm, it looks more or less similar. So I'm not quite sure if this could be in the future problematic for the neurosurgeon.
Well, probably, I think that the consequences of complication are different. I mean, when you look at the MCA, it is. I think one can say that it is a safe procedure. Yeah, and again, the intra-aneurysmal flow breaker has certain morbidities that you cannot predict, like recurrence, perforation, thromboembolism and so forth. Yeah? But at the basilar tip, of course, with the same complication profile of the web device, your surgery has a different complication profile. So of course, it weighs towards the web device, the basilar apex. But of course, it weighs towards surgery at the MCA bifurcation.
Another question from me. So you gave the results, or you showed some papers about the stent results, but I sometimes ask myself if they are not biased towards more negative results because it was a case selection of more difficult cases. What do you think about this?
That's true, and there are even high quality papers saying that there's no difference. But at least there's no paper saying that the morbidity is lower with the stent. Yeah? So of course you have an additional device, and this device is inside the artery, and it's prone to thrombosis and then stent occlusion and emboli. So it cannot be the same. Yeah, and you need anticoagulation. So it must be higher, but of course it's not so dramatically higher. But at least it should be appreciated when you do your risk assessment between different treatment strategies.
There are two last questions asking about the line between conservative management and active intervention according to size of aneurysm. Which size should not be operated if not ruptured?
Well, we have the ISUIA results, but we also have scores that try to help us. I don't have to explain phases and then unruptured score, but of course it makes perfect sense that certain small aneurysms might be more rupture prone than others. Let's say PCOMs, posterior circulation, or also ACOM. You have smokers, you have hypertensive people, and so forth. That means size is, I think, is the most important surrogate parameter for as long as we cannot measure or detect wall thickness by 7 Tesla MR. Doesn't work. But if you want to hear millimeters, well, I would say 7 millimeter is way too large. 5 millimeter makes perfect sense. If you have something smaller than 5 millimeters, but you observe aneurysm growth, you should consider treatment. If you have a patient with significant risk factors in those scores, with a smaller than 5 millimeter aneurysm, you should still consider treatment, unless some other parameters indicate otherwise.
Okay, and the last one is, do you use adenosine to facilitate clipping of aneurysms, or only in the cases when the aneurysm is rupturing?
I have used adenosine for AVM embolization, and so I used high flow AVMs with glue, and when the heart stopped, I injected the glue. So I played with pressure and then the adenosine. So bottom line, I like it. Yeah. And then we are trying to set up this, but we have never used it. Neither pacing nor adenosine. But I think it's very reasonable, of course.
For me, it's the period of the low blood pressure is a bit too short if you're in a, let's say, complicated phase of your surgery. Okay, I do not see any further questions. I look into the chat, and there are many remarks that they thank you for the very nice, interesting, outstanding presentation. The same holds true for me. So I liked your presentation very much. And I'm happy that you have been with us today. And I hope that I will have many of the audience again for the next Eans webinar of the vascular section. Thanks again, and have a nice evening. Bye-bye. Thank you.
Thank you. Bye-bye.